So, good evening, everyone, and we welcome you to this special series of lectures, and it would be learning sessions and teaching sessions. And this is in collaboration and the initiative of our very own Dr. Gopal Badlani. We all know Sir since we were students, and we have seen him coming and teaching and demonstrating surgeries, and we are in awe of his skill and his knowledge. And it is a great pleasure that ISU will be conducting or holding his programs once a month, once every alternate month. And this would continue for the next year or so, and definitely after that also, but we have the program list for the next year. And I request our president, our beloved president, Dr. Sanjay Kulkarni, to please start this webinar, and I would hand over the mic to him.
So I welcome Dr. Gopal Badlani. I just want to tell a little bit of history, like what our Honorary Secretary Lakshman Prabhu was talking about. I met Dr. Gopal Badlani in 1983-84. I don't remember the exact year, and that was the Edinburgh Urology Festival. And he presented a video on a patient with a duplex system. So in the duplex system, there were completely separate pelvis joining below to the ureter. One was dilated and one was normal. So endoscopically through the PCN tract, he created a channel between the two pelvis, the high pressure system and the normal pressure system. And that was like a shunt between the two ends of the pelvis. And I remember that was well appreciated because PCNL at that time was just beginning, and being from Long Island Jewish Medical College, this was a new technique described for the first time. I will describe Dr. Gopal Badlani as professor and vice chair at the Wake Forest University. Most important, he is the roving ambassador of Indian urologists around the world, including he was honorary secretary of AUA and then multiple other important organizations. And now I think he's one of the most traveled and respected urologists from India around the world. So we are very happy to have Dr. Gopal Badlani here with Dr. Pawan Vasudeva, who is professor of urology at VNMC Delhi, and he has keen interest on neuro-urology. So I will hand it over to Sujata to invite the next speaker.
Yeah. So I just request Dr. Lakshman Prabhu that he is still online, and then he can just say a few words, and Dr. Chawla too.
I would only say that we are all very eager to listen to Professor Badlani, and I would just say that Dr. Badlani has always been the best friend of Urological Society of India. Thank you very much, sir, for this series which you have started, and we are so grateful to you. I have no doubts in my mind that we will have a wonderful session. Without taking much time, I will probably now hand over to the chair of Indian School of Urology. Sujata ma'am, over to you, and all the best for this.
Yeah. So Chawla sir, would you like to just say hello? Otherwise, we could hand over the session to Dr. Badlani sir, and request Dr. Pawan Vasudeva. Both of us are here to, and Dr. Pawan Vasudeva would moderate the session. So, sir, we can start with your presentation. You could give us an overview of how would you progress today, and then we can go ahead.
So thank you very much. All of you have been very kind to me. I come home with a very selfish need of coming home and enjoying all my friends' food and family back home. So you facilitate it, and I appreciate it. So it has always been, I'm always grateful to my education in India and my training in India, which enabled me to reach where I am today. So credit should go to Dr. Chawla for putting this together. We spent quite a bit of time, both before and after the USI meeting, to plan this. And really, I'm so pleased to see the efforts that the education school and education cell is making in India to facilitate learning. And I'm happy to contribute, and hopefully this series will help. So this will be a very basic start to learning, and it is directed for the residents. So my apologies to all the senior faculty that this may seem redundant to you. I recognize that
So we can't hear you. Is the volume switched off?
Can you hear me now?
Yes, sir. This is perfect.
So sorry. So the goal today is to learn about neurophysiology of the lower urinary tract. And then also, some reason this is not advancing. Sorry, I'm having some technical difficulties in advancing the slide. Okay, so the focus after the basic neurophysiology will be on the neurological lesions and how they affect lower urinary tract. And the guidelines which are available from the AUA are very helpful, and you should learn. There is a guidelines app from the AUA, which would be very helpful. So it's always good to start with some anatomical understanding of the lower urinary tract. There's a subtle difference between the female and the male in terms of the outlet. The bladder physiology is about the same, but the outlet in a female, the focus is on the mid-urethra, whereas the male has two sets of sphincters, which is the inner and the outer. And the third, according to good people like Sanjay Kulkarni, they've talked about the additional sphincter, which is present. But focus is primarily on the two groups of sphincter. This is involuntary, and this has a voluntary component as well as an involuntary component. And this is important to remember in terms of the physiology. So in terms of the neuroanatomy, the outlet is innervated differently than the bladder body. The innervation is the same in the male and the female. However, the sympathetic outflow in the male is much more predominant than in the female in the outlet. The pelvic floor is innervated similarly. Although we have learned neurophysiology over time, learning the neurophysiology of the mucosa and the submucosa has been a new science over the last decade or two, because the innervation of the submucosal plexus is taking a lot of initiatives in the sensory component and the overactivity that relates to sensation that comes from the bladder. Interstitial cystitis would be an example, or inflammatory lesions such as UTI, etc., would be another example of where sensation drives the urinary symptoms. So that is mucosal and submucosal. Underneath the mucous membrane, there is the smooth muscle and the connective tissue that allows the stretch receptors to be perceived. The outlet itself needs to be assessed more in the female than in the male in terms of the height of the mucosa. So this is non-neurological, this is more hormonal based, but that plays a role in the coaptation and continence of the urethra. So basic neural innervation has been described as the bladder itself is an autonomically innervated, whereas the external sphincter is somatic, which is important to know that the sacral micturition center, which is S234, with S3 being predominant, is the center. You learn this more while doing neuromodulation, which is not popular in India as yet, but something that you're going to learn in the future in terms of placement of the leads in S3 foramen. The other focus is the sympathetic outflow, which is T10 to L2 or T9 through L1, depending on the description. These hypogastric nerves or splanchnic nerves come down. They are very important in the presacral area, where they mix with the parasympathetic nerves and they innervate the bladder. Their focus is both on the bladder body, which is beta sympathetic, and the alpha sympathetic is in the outlet. This is what the drug usage is based on. The alpha sympathetic is you use all the time, the tamsulosin to block the alpha blockers. And then you have the beta adrenergic, which is the beta-3 agonist that you use in terms of calming the bladder down. And the muscarinic receptors here are parasympathetic, which is what the drug usage is based on. So learning the neurophysiology allows you to use the drugs appropriately. So the cholinergic receptors or muscarinic receptors are predominant M1 through M5. M2 and M3 are predominant in the bladder. And the various drug manufacturers will try and tell you that one is better than the other. The distribution described is based on a normal bladder. There's not much in the literature regarding an abnormal bladder or neuropathic bladder where which predominates. However, drugs that are work on both. One may work more than the other. So darafenacin may work more on M3, whereas important to know that M1 is an important receptor as far as blood-brain barrier. Alpha adrenergic, again, can be selective subtypes, and the beta-3 in the beta adrenergics are important adrenergic receptors for the drug usage. So once again, the detrusor muscle is muscarinic as well as beta-3. Trigone and the outlet is predominantly alpha, and the pelvic floor is nicotinic or pudendal nerve, and the urethra is again predominantly alpha sympathetic. So if you're going to use drugs, you have to use according to the blockade or augmentation of these receptors. So although not on the market, and use medication like Sudafed puts patients in retention based on the fact that alpha agonist tightens the urethra in a male who's partially obstructed, can put them in retention. So on sinus medications or alpha Sudafed medication, the labeling says it may cause retention for this reason. The neuroreceptors also have preganglionic and postganglionic, and there's a subtle difference in terms of the coordination of the nerves happening at that level. The use or denervation that occurs preganglionic and postganglionic is important in terms of neuromodulation and whether you can recover nerve function. We've talked about the receptors and the drugs. Most important to remember that these receptors are not selective to the bladder. So all the side effects, particularly with muscarinic receptors, is based on the fact that these are present in the eyes. So you get dry eyes, you get a dry mouth, you can affect the heart rate, you can cause slowness of the stomach or constipation with the bowel. And of course, your intended target is bladder to reduce contractility. Regulation of the urinary tract is important. Although it's autonomic, it's under your volitional control. You control the bladder, at least most of us do. The somatic nerve system normally controls the voluntary function. And really, the external sphincter muscle, the pelvic floor, is the voluntary component. And rest of it is all involuntary, but it's a learned behavior that you teach your bowel and bladder to be socially appropriate. So how does that occur? Regulation of the micturition cycle. The contraction is predominantly autonomic, which is a reflex phenomena. Relaxation of the pelvic floor is mostly autonomic based on the bladder neck and the proximal urethra. However, it requires volitional relaxation of the pelvic floor to urinate. You realize this most when you're in a public place and you have a difficult time starting. That's because your pelvic floor doesn't relax completely and does not allow you to urinate. or if somebody's watching you, you cannot let go. That's predominantly based on the fact that your outlet is still closed. You can also volitionally close the outlets. That means you can stop urination by contracting the pelvic floor, and reflexly the bladder will shut off. It's also an important coordination that you got to remember, particularly in patients who are dysfunctional voiders. When they bear down, the pelvic floor tightens against it. And that's something that you need to remember in a dysfunctional voiding, or teaching patients how to void properly, that they need to learn to relax their pelvic floor volitionally. So normal voiding requires inhibition or stopping of the sympathetic outflow, which is normally keeps the bladder neck closed, and it requires contraction of the parasympathetic reflex pathway to cause contraction of the bladder so that the bladder can urinate. Bradley, a neurologist, described this hypothetical of way of coordinating the whole process. And in his description, he described loop 1 as being as the brain conscious center in the frontal lobe, connecting to the midbrain, which is the pontine micturition center. This loop primarily is inhibitory. Our bladder is inhibited 99.9% of the time. You void maybe 8 times or less in 24 hours. If not, then you have an overactive bladder. And each time it's 25 seconds or 30 seconds. So it's really 5 minutes out of 24 hours that your bladder is working. Rest of the time is shut off. It's not a conscious phenomena, and it occurs at the frontal cortical level that your bladder is under inhibition. If you interrupt this loop, bladder becomes uninhibited. And this is realized in patients who have an injury at the cortical level, which is a cerebrovascular accident, MS, traumatic brain injury, brain tumors that can cause a cortical injury, which will result in interruption of this loop, and the bladder becomes uninhibited. However, 40% of overactive bladder is not recognized why it happens. And on an MRI functional scan, you can see more activity in the brain. So it's happening at the cortical level. The second loop starts in the bladder, sensory stretch receptors that come to the spinal cord, S2, 3, 4, cross over and reach the pontine micturition center. The motor fibers then come down through the sacral micturition center, parasympathetic nerves, back to the bladder. That's loop 2. Now, loop 2 obviously has 2 parts to it, in the spinal cord and outside the spinal cord. And the injury at the level above the sacral cord will have a different effect than the injury outside the spinal cord. It's an important concept you remember from your neurology days, upper motor neuron and lower motor neuron. So lower motor neuron injury is outside the spinal cord or at the sacral level. The upper motor neuron lesion is above the sacral cord. Now, Bradley also described the coordination between the bladder and the sphincter occurring at the spinal level. However, it was recognized later that it does not happen at the spinal level. It happens at the pontine micturition center. That's the coordinating center where the contraction occurs and the sphincter relaxes. That coordination occurs at this level. So the final loop 4, which is described, is the motor cortex controlling the external sphincter, which is like any other skeletal muscle. So now you got to think in terms of what happens differently. So now you think of a newborn child until they are trained, until they learn potty training, their bladder is working at the pontine micturition central level. So the bladder fills and empties in a very coordinated fashion. The sphincter relaxes and they void sometimes right on you. because they don't have any social concept. That's the difference between a spinal cord injury patient and a newborn. In a newborn, the voiding is coordinated but not socially controlled. In a spinal cord injury patient where the injury occurs here, the bladder and the sphincter lose coordination and the voiding occurs reflexly, however, in an uncoordinated fashion. That person also doesn't have a sensation, but there's a big difference between coordinated and uncoordinated voiding. So we'll go into this micturition cycle a little bit more. So now you think in terms of bladder filling. This is not a conscious state. You're not aware of your bladder filling. It is occurring because the sympathetic outflow is keeping the outlet closed and the bladder is not activated, being inhibited by the cortex. Your first sensation is perceived by the stretch of the bladder. The nerve sensation comes to the spinal cord. It reaches the pontine micturition center. It's perceived at the cortex, and you decide, I don't want to go, or I want to go at that point. You reach a full bladder where you feel a stronger desire, and then you reach an urgency stage if you postpone that too long. But at the normal desire to void, you proceed to urinating. That requires some coordination, desire, turning the cortex, giving you permission to void, allowing the pelvic floor to relax. The sympathetic is blocked and the parasympathetic is contracting. All this occurs in 20 seconds and you begin to repeat the cycle again. Now imagine all the things that can go wrong in that process that you're so rarely conscious of. It's on autopilot most of the time, and it doesn't require any further thinking at all, and the process begins. So I'm going to be having a lot of reminder slides so that you remember this as a concept rather than trying to memorize it. Bladder filling is a sympathetic phase. Sphincters closed, pelvic floor closed, muscles relaxed. Filling phase, first sensation is ballpark figure of 100 to 250. This is a learned behavior. This changes in certain condition, and that is based on the delta fibers that are present in the bladder that are normally dormant, not part of normal micturition, but become activated during an inflammation, such as a urinary tract infection, or in a chronic inflammatory situation, such as interstitial cystitis. So sensation is early. Without contracting the bladder, they feel the sensation and they respond to voiding. This is also an anxiety response, a learned behavior, where a person is voiding with every first sensation, yet they fall asleep and they sleep the whole night. So that's a sensory frequency, and that can be separated by history. So the strong desire to void and decision to void causes urethral sphincter relaxation, pelvic floor relaxation, and muscle contraction. This is a board question on a multiple choice. What is the first act of micturition? And the first act of micturition is silence of the pelvic floor before the bladder contracts. It's a few milliseconds that occurs. So the answer to the question is pelvic floor relaxation. And this cycle begins again when the urination occurs. So you have an overactive bladder, which can contract the bladder. And depending on your outlet, you're going to have leaking or no leaking. Depending on your strong outlet, you may be able to close the sphincter until such time you make it to the bathroom. Most of us manage to do that. Sometime a drop or two will leak out. In patients who don't have an adequate pelvic floor, they'll leak out the entire bladder. So urgency of frequency, or urgency incontinence depends on the balance between the bladder contractility and the pelvic floor. In the reverse, the stress incontinence is based purely on mechanics. that means bladder pressure for that moment exceeds the urethral sphincter, the rise is due to intra-abdominal pressure, not due to bladder contraction. Again, a keyboard question. What's the pressure in the bladder? What's the net detrusor pressure in stress incontinence? The answer is 0. So you can have stress incontinence, which is bladder driven because of bladder compliance, bladder pressure being high, more than the outlet in a neuropathic situation, such as myelodysplasia or radiated bladder. But stress incontinence, the net detrusor pressure is 0. The leaking is due to Valsalva leak point pressure, not due to detrusor leak point pressure. You can certainly have mixed incontinence, both urge and stress, which is most common in women as a mixed incontinence. So we talked a little bit about the upper motor neuron or lower motor neuron lesion. You can also have mixed injury. You can have a patient with a stroke who also has diabetes, and you can have mixed lesion depending on the neural involvement. So this is a key slide. I want you to remember this slide as the key, that the cortical function is inhibitory. Interruption here will lead to bladder inhibition being lost. The pontine micturition center is like Dadar station in Bombay, where there is all the crossover of trains and people. This is where coordination happens. All those dabawalas coordinate at Dadar. That's where the occurrence occurs. If you have injury at the pontine micturition center or slightly below, you lack the coordination between the bladder and the sphincter. If the injury is outside the spinal cord or at the sacral micturition center, you have bladder that is areflexic. And there is a subtle difference between anterior horn and posterior horn injury. So a diabetic bladder is a posterior horn injury. So the bladder compliance remains normal, pressure doesn't rise, patient doesn't feel sensation of filling. Whereas if you have an abdominal perineal resection, radical hysterectomy, you have a motor injury which causes lack of compliance. The bladder pressure rises. So both are areflexic, but one is more compliant than the other. And I mentioned the C fibers, which is the unmyelinated silent fibers, which only come alive during a UTI. They're supposed to become quiet again, but in some patients, they do not. So this is one slide that you must remember as a concept so that you can then fit in anything that occurs into this picture. Of course, the patients don't read the book, and they come with multiple situations where there's crossover. So you can have a patient who has Parkinson. Typically, the patient is older. He also has BPH. So we don't know whether the symptoms are due to BPH, enlargement of the prostate and outlet obstruction, or due to Parkinson. You can have a patient with stroke also having diabetes. So these are predominantly cortical injuries. You have peripheral nerve injuries, where diabetic neuropathy would be the most commonest, or surgical pelvic plexus injury. Then you have spinal cord, which occurs, MS can occur at any level, spinal cord or in the brain. You have disc disease, which is a partial injury, and depending on the level, you can have various symptoms. Most prominent is myelomeningocele, and most people believe myelomeningocele is a sacral injury, so it should be a bladder that is acontractile or areflexic. The fact is, majority of the myelomeningocele have an upper motor neuron lesion or a mixed lesion. So you have certain neuromuscular conditions, such as myasthenia gravis, which is at the neuromuscular junction and can affect volitional contraction, but not the smooth muscle. So why do we understand, or why do we need to learn about neurogenic bladder? The primary focus as a urologist is to protect the upper tracts. storage pressure is supposed to be low, which can be affected in a neuropathic patient, and that results in injury to the upper tracts, which is hydronephrosis, leading to renal failure, and was the most common cause of death in neuropathic population, particularly spinal cord. Once we have learned to improve the bladder, all this has stopped, and simple insertion of the catheter and draining the intermittent cath modified all these patients' behavior in a significant way. The symptoms not always present. They can present as incontinence, and patients desire only to be dry, even at the expense of the upper tracts. But your goal is to preserve the upper tracts. And of course, recurrent UTI and stones. The stones occur not only due to the infection, but also due to lack of mobility in this patient, and they have demineralization of the bone. So there's a high level of crystals in the urine that make stones. So what is the workup of a patient with neurogenic lower urinary tract dysfunction? Whereas history is extremely important, knowing what their injury is conceptually allows you to evaluate them. Exam is a physical exam where if you have a known injury, you can select out. So simply a diabetic patient comes to me and has difficulty in voiding or is in retention, and I do a rectal exam and the rectal tone is diminished or lacking. That tells me, and they have lack of perianal or perivaginal sensation, I already know that they have a neuropathic lower motor neuron injury. That sort of confirms I can, yes, go and prove all the different things, but that exam alone tells me what's happening in this patient. So that's a simple example of how you can use level in a sacral spinal cord injury. So having a cervical injury and knowing how much is their hand function will determine your decision in terms of what type of treatment you're going to do. If the patient cannot hold the catheter, then intermittent cath is not a choice. You need a passive treatment for that cervical cord injury. So once again, your exam is very important. And then laboratory, knowing their basic renal function, and an assessment of the upper tracts is important. The lower tracts comes in time of management, what to do about it. So in the history, how long have they had the neurologic problem? What are their urinary symptoms? What have they been doing thus far? How do you manage your bladder thus far? And most spinal cord injury or neurologic patients wish to do is to have void normally. They believe they can make it, they can do it. And they're doing it by straining, pushing, trying to get it. As I mentioned, their hand dexterity is an important function. Don't forget to ask about their bowel program or bowel function. And if they have a high spinal cord injury, it's important to remember if they had autonomic dysreflexia, because that's a key history that can get them in trouble. There is a wonderful guideline algorithm that is present at the AUA website that you can see in the initial evaluation, and then you decide if this is a low risk injury or high unknown risk or high risk to determine how you should go about. So low risk is suprapontine. These patients will have bother, they'll have leaking, but unlikely to affect the upper tract in terms of the injury, whereas the moderate risk and the high risk can cause upper tract injuries, so you need to assess them further. In terms of, the surveillance that is also prescribed in terms of what to do in terms of surveillance, this requires reevaluation at a prolific time in terms of the moderate to high risk, but less so in low risk patients. The other classification that you need to learn, particularly in spinal cord injury patient, is called the Asia classification. And depending on the type of injury they have, The grade E would be the patient is nearly normal or normal with all intact, where their grade A would be a high cervical cord injury. And most patients form into B or C because the impairment is always incomplete. They don't have as many sensory function, etc., but they have a level to which they can preserve their function. So knowing their disability and knowing their gradation allows you, once again, your management plan. There is an ASIA score available, which is important if you're dealing with a lot of spinal cord injury patient. This is something worthwhile learning. If you're going to see a patient on an occasional basis, then this may not be important. Upper tract evaluation is recommended, just starting with a sono and a KUB if necessary. If you have hydronephrosis, a renal scan is helpful. Cross-sectional imaging, if you have stones, IVP is a given up art. Creatinine clearance is helpful. Usually the nuclear scan is only important if you have hydronephrosis and you want to know differential function. Voiding or catheterization diary is an important initial evaluation because it tells you their pattern as to what they're doing, what their volume is. Urodynamic evaluation can be done at your initial consult or at least 4 to 6 weeks after initial injury. Cystoscopy is indicated only for hematuria workup and or catheterization difficulty. The imaging, we typically do a voiding cystourethrogram as part of the urodynamics as a video study to assess for reflux, etc. at the same time. At the baseline, we assess their function with known risk of complications where there's high risk patients. We would do a assessment earlier to know what their higher filling pressure is or compliance is, or external sphincter dyssynergia, because those are all the things that's going to affect the upper urinary tract and knowing their. So dysfunction functionally is classified as failure to store or failure to empty. The failure to store can be because of bladder overactivity or due to the fact that the outlet is weak, causing lower motor neuron injury. So you have a patient with a lower motor neuron injury, a low sacral cord injury, who only leaks while transferring. That leaking is due to the outlet, not due to the bladder. The bladder is going to be flat. It doesn't empty. It requires intermittent catheterization, but they leak with certain times, particularly when they use their upper body to transfer, upper body to lift. That's a patient that requires an outlet procedure, not a bladder procedure. Failure to empty, again, can be due to lack of bladder contractility, which can be complete areflexia or hypocontractility, such as in diabetes. Depending, again, on the level of injury, you'll have overactivity or underactivity. Typically, underactivity occurs due to peripheral nerve injury, rarely with stroke, rarely with MS, and very low sacral cord injuries. Outlet can be simply enlarged prostate, nothing to do with the neuropathic situation. However, in a spinal cord injury patient or MS patient, the first thing you think about is bladder sphincter discoordination. Whereas the Parkinson patient, it's not true dyssynergia, it's lack of relaxation. Just like they have cogwheel rigidity of the rest of the skeletal muscle, the pelvic floor behaves the same way, and they get very frustrated because they have the urge to go and the sphincter doesn't relax, and they walk away, and then suddenly the sphincter relaxes and they become incontinent. So autonomic dysreflexia is a phenomenon that you must be aware of, because any noxious stimulations, simply a catheter or digital evacuation of the bowel, can trigger this reflex. And its sympathetic cord is not constrained. The injury is above the sympathetic cord. So the injury has to be T7 or higher or T6 or higher so that autonomic dysreflexia can occur. and they can get uncontrolled hypertension, so much so they can either die from it or they can develop a stroke. So you have a patient who was paraplegic and then they got a stroke, so they became triplegic. That's a disastrous injury, and it's easily terminated or prevented, that you have the bladder emptied immediately or have these chemicals available that that you can treat the patient in an urgent fashion. So what are the urodynamic parameters that you look at? These are all the different things we've talked about. Most important, hostile bladder, which is lack of compliance, or high pressure in the bladder is something that you need to recognize. So this happens in the upper tract imaging, the safeguard the upper tracts per se, and there are a variety of injuries again. So here is a bladder that is areflexic. There is no contraction of the bladder at all. There is still some sphincter activity that is occurring. The relationship, the compliance is the assessment of bladder pressure as you're filling the bladder and the ability of the bladder to accept that fluid, which is an important aspect to understand. So here you see the bladder pressure is slowly rising with filling. That requires a higher pressure than causing leaking. This is a poorly compliant bladder, whereas the sphincter activity is still present that you see here. So filling compliance is very important. So that can then lead to high degree of reflux that is occurring. The outlet is closed. The bladder filling pressure is high. It forms a pop-off either as a diverticulum or as a reflux that then results in the situation. So in doing so, you can have detrusor overactivity when you have upper tract injury or upper motor neuron lesion. You can have detrusor activity that occurs at capacity that you cannot suppress. Normally, when our bladder contracts, we are able to shut it down, whereas in this particular group of people, you don't have this ability to stop. And this will determine the treatment. So if the bladder contraction is occurring at 50 cc's, I cannot teach that patient bladder training program. Whereas the contraction is occurring at 300 cc's, I can have the patient void every 2 hours and not get affected by that unstable contraction. So that's the difference in knowing at what volume is the unstable contraction occurring in terms of your management. So neurological situation or idiopathic DO is most common, whereas when you have DO due to a known bladder injury, that can be termed as neurogenic detrusor overactivity. Now, DHIC is a person's bladder contracts early, they have urgency, but the contraction is not strong enough to empty the bladder. So you have both situations. Person presents with urgency and frequency and incomplete emptying. And when you do the study, you see these phasic or contractile activity at low volume, and their bladder doesn't contract to empty. And this is a difficult condition to treat because if you empirically, based on symptom, give them bladder drugs such as anticholinergics, which will put them in retention. So management is usually a combination of medication and intermittent catheterization that can occur. DSD requires and typically occurs with suprasacral injury, and because of the high pressure, you have to judge how you're going to treat it. Either you're going to paralyze the bladder with Botox injection today and treat with intermittent catheterization, or cut the sphincter and make them completely incontinent. Two completely different schools of treatment for those patients. So here you have, bladder is contracting, the sphincter is contracting at the same time. Fluoroscopically, you can see the spinning top of the outlet, which is stopping at the external sphincter level. And you can see in the phasic fashion, if the volume at which they're contracting is 300, which is good, but if it's occurring at a smaller volume, then it's a bigger problem. So this is a recap again. Injury above the pontine micturition center. All these conditions, detrusor overactivity. If you have injury here, overactivity with sphincter dysynergia. If you have injury at the sacral cord, you have areflex, impaired contractility, and may affect the external sphincter as well. So those are different ways of remembering what can happen with activity. So lower urinary in patients that have traumatic brain injury, it's like a stroke, except they're typically younger patients. So they can have overactivity, but without incontinence per se. Depending on because the injury is above the spines, it virtually never has external sphincter dysynergia as a pattern. Unless you have global injury to the cortex. This was a study we did very, very long time ago, actually at Nair Hospital in acute strokes. And we published that in the Journal of Urology, I don't know how long ago, to see the different patterns of location versus stroke. CVA is a very interesting injury. Initially, post-CVA, you get bladder areflexia, very similar to a spinal cord injury. And this is where you need to be preventing by draining the bladder and preventing overstretching. As the time progresses, you will have detrusor overactivity. Once again, a board question. Urodynamic finding in a CVA, most commonly detrusor overactivity or detrusor hyperreflexia. 20% will have areflexia due to the fact that they have diabetes at the same time, and a portion of them will be normal. If the question is asked differently, this is a key point I want you to remember. Incontinence improves over time with stroke injury. Is that because the bladder got better or the patient got better? Well, typically it's patient getting better. That means their mobility got better. They can get to the bathroom faster. And that's why the incontinence got better. Not necessarily that the bladder got better. Typically, like I said, they don't have external sphincter dysynergia present in this patient. If they have high PVR, it's a male patient, you need to either rule out bladder underactivity or they have outlet obstruction present at the same time. A word of caution, avoid doing anesthetic and or surgery in patients with stroke within the first year after stroke. They have a high mortality rate in that particular group. So try and do the less invasive, lack of anesthesia procedures in these patients, temporizing till they're able to undergo safe anesthesia. I'll skip over this. So when you have detrusor instability versus detrusor hyperreflexia, this is in combination in these patients. A cheaper way to assess if a patient has bladder overactivity and poor flow, if you give them anticholinergic and they go into retention, it's a way to say that they have outlet obstruction. At least you know the overactivity will respond after you do the outlet procedure. But patients with MS and or Parkinson is much more difficult to predict what's going to happen to their bladder behavior. It's important to do that. Now, there is specialized test. It's called the micturition urethral profile. I learned all my urodynamics with Subarao Yala. He described this technique, which is actual pressure measurement in the outlet as you are assessing the function of the outlet. It's a difficult test to do and not practical in terms of assessment. So TURP after cerebrovascular accident, like I said to you, the patients have better continence and mobility if you wait a while before you do the surgery in these patients. I'll skip over this patient. So in patient with Parkinson, it's called pseudo-dysynergia. This is often misdiagnosed as detrusor external dysynergia. They again have the two sets of fibers or locations in the pontine micturition center. You can have overactivity as the predominant symptoms, where there's a group of Parkinson patients where they have areflexia. So it's only by urodynamics and symptoms that you can separate the two out. This is a difficult group to treat, as anticholinergic medication were almost contraindicated in patients with Parkinson. The beta-3 gives you an option, but today Botox most likely gives you the treatment options. However, these patients cannot do self-cath. So it's a very difficult group to treat. They are older, they have bladder overactivity, and they cannot do self-cath. So treating the bladder overactivity, it becomes an extremely difficult situation. And you passively back into a suprapubic tube catheter drainage in these patients if they are severely impaired, because there's nothing else that is practical in these patients. So a Parkinson patient, typically the injury is more depicted here, that the bladder is contracting, but the sphincter takes a little while to relax. So as opposed to dyssynergia, which keeps increasing the external sphincter activity, this takes a longer time to let go. This is where they'll void. And Dave Stotskin described this ability to predict which patient will do better surgically. If they have external sphincter that's volitionally controlled by either assessment of the rectal sphincter or the external sphincter, they will do better. If they have no volitional control, they'll do poorly postoperatively, and they'll have more incontinence than that. Spinal cord injury varies depending on the level of injury. Again, you have spinal shock, which lasts for a variable time, and where you have flaccid paralysis. The somatic function returns earlier than bladder function. So if they have return of detrusor, they will have it after the somatic function has returned, because somatic nerves are larger. So way back, World War I and World War II, spinal cord injury was the reason why people died from bed sores and infection. It's a male injury predominantly, and at least in the US, I think in India too, it's a motor vehicle accident is the most common injury that occurs, and complications account for majority of the morbidity in these patients. As I said, falls or sports injury are other types of injury that occur. We've gone over this separation of what the injuries are and then stages of management. So there is the immediate management, which is passive, to drain the bladder with a catheter, or certain spinal cord injury centers have intermittent cath teams that drain the bladder intermittently. You have early, intermediate, and long-term. So immediate injury is predominantly the trauma center manages them with advanced trauma life support, stabilization of this fracture, and a catheter is placed. In the intermediate, you can have the catheter removed and an intermittent cath done by the nursing staff. Once able, the fracture site is stable, and the patient can be taught how to do self-catheterization. If you start early, you can manage the bladder. Some patient obviously will not be able to do that. They will require indwelling catheter, which is the frail elderly. Women, patient with tetraplegia or quadriplegia won't be able to do that. After a few weeks, you either have controlled voiding situation where they're able to urinate, or you have contained incontinence using a condom catheter drainage. Effective bladder emptying is best done by intermittent cath. Patients who require long-term indwelling catheter should be converted to spinal suprapubic tube as early as possible. McGuire described advancing or starting antimuscarinic even before their bladder function is returned to reduce the bladder overactivity. This is not universal, however, it's recommended. Baseline ultrasound is what we do for these patients in terms of assessment and then doing their upper tract management. So once again, The goal is to preserve renal function, and the management includes goal at trying to have contained or controlled continence, incontinence, or drainage. Today, most commonly, we will try the antimuscarinic. Botox is the mainstay of treatment. Rhizotomy and sacral nerve stimulator was described by Brindley and not done commonly today. Emptying predominantly relies on clean intermittent catheterization. And long-term, in a young spinal cord injury patient, we might do an augment and give them a continent stoma, which is done more for females than it is males, because female has better access through the umbilicus to drain her bladder rather than leaning forward. Remember, high spinal cord injury patients cannot lean forward, so they cannot do intermittent cath, particularly in females. Condom, which is cutting the sphincter and applying a penile sheath, is a passive and less commonly done. We used to do this in Texas rehab a lot because we used to put artificial sphincters in them after cutting the sphincter, which is not commonly done. So sphincterotomy is something that you need to be aware of. I went through a period of where we did a urolome stent across the external sphincter, but sphincterotomy requires a special skill because your entire life you've learned not to cut the sphincter, and now you're deliberately cutting the sphincter. So you always end up undercutting it. And you should try and preserve the bladder neck in most of these patients so that they don't have continuous incontinence. A rare patient will have internal sphincter dyssynergia, which is an injury that occurs at the sympathetic cord level, and that needs to be recognized and diagnosed only on fluoroscopy. Suprapubic catheter is preferred over indwelling urethral catheter to prevent urethral trauma, and continent diversion is valid for paraplegics, ileal conduit for quadriplegic patients. You need yearly assessment, and then depending on their recovery, you may expect what's going to happen. The upper tract is affected by the bladder pressure. So all your goal is to lower the bladder pressure. Essential to establish a management plan with the patient, and do not treat the neuropathic patient just based on symptoms, and do not use treatment based on supposition. You have to understand and establish what their pattern is before you initiate treatment. These are different patterns. So MS is a more common. Unlike Parkinson, this can occur in young and old patients, and they present with frequency urgency. They believe they're normal. And if you put them on anticholinergic and they develop a high PVR, then you know that they're having bladder sphincter dyssynergia and they need to be assessed. Females more common, and their symptoms don't correlate. And part of it is if they have cortical plaques, they also have impaired cognition. So they yes you to death, but they don't understand what you just said. So it's important to assess that all the time. Another board question: what is the most common finding in MS? Overactivity. Overactivity with external dyssynergia, and less commonly impaired contractility. So this is a changing behavior because MS waxes and wanes, goes up and down, so their bladder behavior can also change. We talked a little bit about pelvic plexus injury earlier, and this I'm rushing through because we're reaching the hour. So neural effect is multifactorial: hypogastric sympathetic nerve injury or parasympathetic. So this typically occurs in a lower motor neuron type of lesion. You had a low anterior resection or abdominoperineal resection, patients in retention, and you do TUR, and then they're incontinent. And that's because they had denervation of the pelvic floor, denervation of their bladder. And it's important, if the person's retention, we recognize what's happening. You can't do a rectal exam because the perineum is closed. So you cannot assess if they have denervation or not. So you need to do a study to know whether the bladder is contracting or not. If the bladder is contracting, it's unlikely they have a neurologic injury. Pudendal nerve injury is much less common because pudendal nerve travels on the floor of the pelvis. It's harder to injure than the parasympathetic nerve. So typically it's the bladder's nerves or the outlet that are affected, and your surgery may not be useful. So it's better to put them on intermittent cath, let them stabilize, do a study, and then decide how you're going to treat them. Diabetes is much more common, and depending on their neuropathy, once again, there is a portion of patients who will have bladder overactivity instead of the underactivity that's common in these patients. So that's very important to recognize. So diabetic cystopathy is underactivity. They can have associated outlet obstruction, but a portion will have bladder overactivity. Whether it occurred from obstruction or diabetes related, it's unknown, but early diabetes can have bladder overactivity. In the females, again, you can have cystopathy as the most common cause of this injury. So lower the pressure. I keep emphasizing them. Protect upper tracts is your goal. And this is, again, a diagram to sort of bring everything together, the inhibition, etc. So I will stop here and let's see what else we need to do.
Yes, sir. So there are a few questions in the chat box. Dr. Pawan would please.
Yes, go ahead, sir.
Yes,
So
Pawan, please. Yeah.
Thank you very much, sir, for simplifying what is such a complex topic. So someone in the chat box is asking, is there any role of neuromodulation in neurogenic bladder patients who are younger?
So there is more recent experience in both MS and Parkinson patients that has been, but prior to the recent development of the MRI compatible neuromodulation, it was not possible for us to put these devices because the patient required frequent MRI. So anecdotal and some papers show improvement in MS patients. So caution, not yet an approved use, but it is there in terms of initial experience, not used commonly.
Okay.
And certainly not in spinal cord injury patient. That's it's a Brindley stimulator that that's an implanted to cause contraction of the bladder. So that's important part.
Another question, in a paraplegic patient, would you ever consider doing a TURP for with a diagnosis of BP in mind?
Depending on their bladder contractility. So you remember, paraplegia can be a partial or incomplete injury. And if he's of an age where outlet obstruction is present, I would be cautious in terms of assessing. I would do video urodynamics to know that the obstruction is at the bladder neck level, not at the external sphincter level. That's how I would differentiate, unless I'm able to do that maturation profile. So if the obstruction is at the bladder neck and he has failed alpha blocker, then I would do a procedure. Today, I have the ability of doing a temporary stent, an iTind device, or UroLift. I would do those before I do a TURP on them.
Okay. And what else is there? So for one question I wanted to ask, what is the timing of your urodynamic? When do you do your first urodynamics post a spinal cord injury patient?
Most typically when they are discharged 4 to 6 weeks after the initial rehab. They have trauma center for a few days or a week, then they go to rehab for about 4 weeks. And then at the time of discharge, we don't do inpatient urodynamics. So only when they are discharged. So between 4 weeks to 3 months.
Because there was this recent data that said that even in the initial post injury during the spinal shock phase,
Yeah.
the bladders may not be safe. There was a paper in the Journal of Urology.
I just reviewed that paper recently. That came from one of the Scandinavian countries. I remember that paper.
It was, I think, from the Kessler group in Zurich.
Yeah. So we discussed that in Journal Club, and we found that it was a very selective retrospective patients that they had picked out that they can have early damage. So it's not a recommended guideline at the moment.
Okay.
As long as they're doing intermittent cath, you're not going to change the management anyway.
And patients, so a lot of patients in India are not doing intermittent catheterization and remain on indwelling catheters. And there is a belief that once you put them on an indwelling cath, all is okay. You don't need to follow them up. Would you be following patients who are on an indwelling cath over a period of time?
So again, so it depends on the level of injury. What typically happens, their bladder thickens over a period of time despite indwelling catheter, and they develop a ureterovesical junction obstruction, and they develop hydronephrosis despite having a Foley. So you just need to know where the injury is. An indwelling catheter needs at least 6 months to a year follow-up monitoring. Now, obviously, there is urethral trauma, and I would encourage patients to, if they're going to be managed passively with a catheter, that they have a suprapubic tube placed. But even with suprapubic, they need at least an ultrasound once a year to assess what's happening.
That's a very important message, that the bladder is not safe even if they are on an indwelling cath. They need to still be assessed periodically.
For upper tracts, yes.
Yes. Dr. Sujata, would you want to?
Yes, Dr. Pawan. So, Dr. Chawla sir had suggested that we would have 6 residents on this forum, and Dr. Badlani sir would ask them some questions in relation to a case. So I think the boys are here, sir, in case you would, or maybe we can keep that session of question answers for the next time, whatever you feel like, sir.
I mean, it depends on your day. I don't know how many people are keen to get off this session. I had prepared certain cases if they wish to discuss it. So let's see, I have first case.
So among the residents, whom do we have right here? I can see Dr. Gaurav.
So I have names of 6: Dr. Anshuman, Dr. Naman, Dr. Abhishek, Dr. Charan, Supradeep, and Gaurav.
Yeah.
Yeah, we are there.
Okay. Ready, willing, and able, right? Okay. I won't remember all your names. Thank God you have it written on your, so I can see Anshuman. So this is a patient. She's 24 when she presented to us. It's a case from a while ago. She was born with spinal dysraphism. So myelo patient, she was treated for mixed urinary incontinence. She had a reimplant as a child. She was seen by pediatric urology for quote unquote neurogenic bladder. She was on anticholinergics, which she discontinued during pregnancy. She then stopped seeing, poor follow-up. She was not compliant with her clean intermittent catheterization, and over a period of time, she had these recurrent UTIs. She had a visit again, mostly commonly for recurrent UTI and incontinence, and the medication was restarted. We had a report of a urodynamic done in the past in 2005, where capacity was this much and she had normal compliance. We didn't have a tracing. And she had a MAG3 renal scan to show split function with a questionable obstruction on the right side. So in a brief, very nutshell, she was followed by nephrology, and you can see gradual trend of worsening creatinine over a period of time and multiple visits to the phyllo. Infections were mostly E. coli. This is a current behavior with or without tolterodine. She leaks as well. She has bedwetting. And as I mentioned, her past medical history. She presents, she has a 91 cc PVR. Rest of it is not relevant there. Urine analysis is positive. What would you like to do besides sending her to Dr. Vasudeva?
The urodynamics findings, I would just like to know once again, sir. She was having a 320 capacity.
So that was maybe 15 years before she presented to us.
Okay, sir.
So this is, I'm going to treat you just like I would have a board. So I presented the history and I ask you, what are you going to do next? And what should be your answer? So your answer, be simple. You walked into the room and you've got this history in your hand that I provided you. What are you going to do first? You're going to ask her some questions, right? You're going to reevaluate a history and physical for yourself, correct? And then look at her urine analysis, which I've given you. And then what is the first evaluation you want to do for her? You have a PVR already. That would be something that I would like to know right away. So when I walk into the exam room, I have their symptom score, some, like a UDI-6 IIQ-7 typically. I have their PVR, I have their urine analysis, and I've confirmed their history. What's the next investigation? My whole talk was, what do you want to preserve? What do you want to do?
Sir, we have to get one sonographic analysis.
Okay, sonographic, right. Upper tract assessment, right?
Yes.
So, and then do lower urinary tract. So this is her upper tract. Okay, that's her right kidney. You can see there is hydronephrotic changes. There is hydroureter. Yes? And left side less hydro, still dilated. Okay. So now what?
She's having a bilateral hydroureteral nephrosis, sir. So I would like to have a UDS so that way.
Okay, I have it for you.
Measures. Yeah.
What do you see there?
You want a UDS or you want a video UDS?
Video UDS, sir.
Video UDS.
Okay, you have UDS. I'm showing you these pictures. What do you see? This is the bladder line. This is the abdominal line. This is net detrusor. This is sphincter activity. This is volume infused.
We can see phasic overactivity in the filling phase, sir.
That's an additional line you have to say, at low volume, right?
At
Look at the
low
volume.
Yes.
At very low volume.
Yes. Sir.
Okay. All right. So what else do you want to know? What's happening at that volume, right? She's not leaking, right?
Yes, sir. What is the detrusor pressure at that level? We would just like to see, and also.
Okay, so the pressure, as I read it, is net pressure is about 28, 30 something here. Why is that important?
Sir, because she's having bilateral VUR, sir. Bilateral. So her whether the bladder is safe or unsafe, we need to assess, because
Okay. So
she's already landed up in CKD, sir.
I'm glad you brought that up, I want you to differentiate between pressure that occurs with contraction versus the pressure that occurs with poor compliance, right? Contraction pressure we all have, right? When you void, your bladder pressure rises. It doesn't affect your upper tracts because it's so short-lived, right? Less than 30 seconds. Whereas compliance pressure is sustained, which causes upper tract damage. So it's not the contractile pressure that causes the upper tract damage. So yes, phasic contraction will cause urgency frequency, but it's unlikely to cause upper tracts unless the external sphincter is dysenergic and you're getting very high pressures. This sort of bladder tells me, yes, she gets contracting. She has bladder overactivity. Now, again, this is a point to bring that spinal dystrophism, myelo patients can have this, right? So now you have the video portion of it. You can see the bladder. I don't know how well you can see the outlet, which is more or less, not emptying. You have, but I don't see reflux on this study. One picture I'm showing you. So now what do you want to do for her?
So we need to bring down the bladder pressures during the filling phase, sir. So she's already on tolterodine, as I could see, and she was symptomatically better when she was on tolterodine, and she was having less periods of leak, less episodes of leak. So because of recurrent UTIs, I would like to start her on
So you haven't given me a reason for her bilateral hydronephrosis. Why does she have bilateral hydronephrosis? Bladder की वो picture देखो, याद करो और क्या हुआ? What is it?
Yeah, it's a thick walled bladder, sir. Probably
Correct.
causing
Correct. So how are you going to prove it? How are you going to prove it?
We need to do we need to document obstruction at the level of VUJ, sir.
हाँ sir, तो कैसे करोगे? Retrograde?
No, sir. We need to do a renogram with the region of interest at the VUJ, sir.
Okay, renal scan. But
Yes,
now remember, she has creatinine is up to 5. So renal scan may not work for you with that high creatinine. So we decided, so your problem is what? Supravesical, correct? It's no longer bladder alone. It's supravesical problem. The obstruction is supravesical, and that you need to prove by a renal scan. But we decided to perk her because we needed to address the creatinine. So she had perks, and you can do an antigrade study to show the obstruction. And once her creatinine came down, you can. All right. So now what would you like to do?
Patient is not. Sir, because her creatinine is coming down, so she needs a diversion procedure, sir, because we need to safeguard the renal function.
So what would you recommend?
We can give an attempt of internal drainage in the form of bilateral DJ stenting, sir, because PCN.
Okay, that's an incomplete answer. What else? Partially correct. What else? So stenting overcame the UV obstruction. What else do we need to? You saw her bladder picture. What else do I need to do for
her? And we need to continue her on anticholinergics, so that
And third part? She doesn't void with those.
She,
You
but
have
her
some
PVR
chat
was
box.
90 ml, sir. She was voiding 5 times with a PVR of 90. So maybe bladder training and timed voiding, we have to like ask
So
her.
again, bladder training doesn't work at low volume bladder contraction. If I knock off those contraction with medication, she won't empty. You have a history, she was doing CIC. So if I want to, if you're going to treat creatinine elevation and upper tracts, if you stent it, you need to have drainage at the same time. So
Yeah.
it works only with an
Yeah.
indwelling cath,
Yeah, she
and
yes.
or you have to prove that anticholinergics. I mean, if I'm going to do stenting, and she's a poorly compliant patient, I would inject Botox at the same time to paralyze the bladder. Why put her on anticholinergic? So Botox CIC would be my answer, and see if the creatinine can be maintained with CIC. If the creatinine starts to rise again, then I know she needs an indwelling catheter. What is the other option? She's 24. How long are you going to keep her that way?
We can do a bilateral nephrostomy, sir, so that
She already has bilateral nephrostomy. She's going to live with this for the rest of her life. She's 24. She has 2 little kids. What is the other option?
So vesicostomy.
Vasectomy is not an answer in an adult. It's an answer in a child. Vesicostomy doesn't deal with UV obstruction. So that's a wrong answer. You can't have DJ stents and a vesicostomy. That's not going to be an answer. Come on, think bigger. Supravesical obstruction, how do we treat? Why is nobody coming up with an ileal conduit as a diversion?
Yeah, but
what? It only happens in bladder cancer patients? So?
No, sir. Like, same outcomes can be attained by a lesser invasive technique with the bilateral DJ stenting and the catheter, sir. So
but remember, DJ stenting has to be changed every 3 months or 4 months, right?
Yes, sir. But yeah,
Stenting can't be an option for life, or nephrostomy cannot be an option for your entire life.
Yeah,
she's 24. If she was 85, yeah, that sounds good.
As a patient, I would not accept it.
So anyway, that's, she chose. So this is, I want you to remember this. Hydronephrosis as a result of bladder, not stones. You've taken that part out, all right? Hydronephrosis or hydroureteronephrosis can be due to the ureter, obviously. You have bilateral ureteral pathology, stone or non-stone. Non-stone, you can have benign diseases, retroperitoneal fibrosis, et cetera, You can have intrinsic tumor, constriction, scar from surgery. But if it's bladder, outlet, of course, well, you have prostate and or malignant causing changes. So if you just focus on the middle part, bladder causing upper tract changes, it can be neurogenic or non-neurogenic, okay? In the neurogenic, you typically have upper motor neuron lesion causing bladder sphincter dyssynergia. If it's lower motor neuron lesion, it's his anterior horn injury or denervation fibrosis, or due to radiation that would cause fixed bladder changes to result in supravesical obstruction that then results. It's typically found incidentally, except in these patients who present with lower urinary tract, and you need a workup besides a physical exam. Ultrasound initially diagnoses it. PVR determines if it's outlet. Means if you have a high PVR, it's bladder, neck, and below. That's the problem. You drain the bladder and the hydro goes away. It was the outlet. But if there is no PVR in this, like in this young lady, then you not to think about supravesical obstruction, right? So PVR or no PVR then determines, and then you do a Lasix urinogram, which confirms the test for you, and then you treat accordingly, all right? So we had a review paper on this a while ago, just has all this algorithm for you. So bladder-related upper tract changes, it's a very important phenomenon that you should look at and learn because they are found incidentally. Typically, you have a BPH patient that presents in retention with 4,000 cc's in his bladder and hydronephrosis. The more common finding that you're aware of, bladder doesn't contract, you drain the bladder, hydro goes away most of the time. Female presents with a large prolapse, she can present with upper tract changes, you reduce the prolapse and the hydro goes away. But in these patients who have neuropathic changes, that may not change because the bladder has thickened. So I only see those patients with radiation fibrosis, with pelvic changes, their bladder is end-stage bladder. And the end-stage bladder then requires some determination if you're going to drain the bladder alone, which is the first and simplest. You're going to have lower the bladder compliance or improve the bladder compliance with Botox and drain the bladder as a second. Then you're going to decompress the bladder with augmentation as a third choice, or augmentation and continent. And finally, patients who are not able to do that is ileal conduit. So this lady basically refused an ileal conduit. She lives with intermittent stent change. And I assure you, she's been admitted several times because she fails to come back for a stent change and or stent migrates, continues to play with her kidneys despite having that creatinine. So she's not a safe patient with that kind of a management. So you also need to know what is the patient's ability to follow the care that you're recommending, come back for stent change, and you know how many patients don't come back for a stent change. Then you have an additional problem of stent stones. So that was one case. Any questions related to?
So we have some questions in the chat box. What is the interval that you use for injecting Botox? I mean, how often do you inject?
On an average, every 6 months. Based on your insurance laws, you can't do it with less than 4 months. But typically 6 months. Some patients go longer. I let the patients determine that. So if the patient is a non-neuropathic patient, like a typical overactivity, we inject and we tell them we're going to set an appointment 6 months. If you're still doing well, call us and postpone that. If you're not doing well by 5 months, add oral medications to see if you can prolong. If not, they call us and tell us, I need my next injection.
And in neuropaths, you're injecting classically 200 or are you, or does it?
So if the patients are on self-cath, then I'm liberal in terms of injecting a higher amount. If they're not doing self-cath and they are non-neurogenic, so we start with 100, and depending on the response, adjust on the next injection.
So just one question regarding this case only, sir. Whether when she has already landed up in CKD3, sir, is ileal conduit still the suitable option for her over
Over what? You bring up some really good questions because it leads to another day. So can I offer her a continent diversion?
No, sir.
Why?
Because she's already in CKD, sir, and it will lead to greater reabsorption of urine.
So anything over creatinine of 2, you cannot offer a continent augment or a continent diversion. So her only option is ileal conduit because it's a passive drainage system. It allows urine to drain, and it's safer than stenting and recurrent bacteriuria with that and or unreliability of bladder drainage.
So what is your view on using stomach?
Stomach has been tried in the past. The idea that acidification was better, but it had its own problem. They have recurrent hematuria as a big problem. And in adult population, it was difficult to bring the stomach down to the bladder. In a pediatric population, it was possible. So I have patients who have a stomach as part of their continent augment, stomach as their part of other. And I've had to go back, either alkalinize them or go back and fulgurate those bleeding sites. It's like treating peptic ulcer disease.
Okay. And in your practice, because there was a paper from India only which said that for CKD 3 and 4 patients, an ileal augment was still working. Dr. Sanjay had published this paper. In your practice, what is the cutoff GFR at which you move away from an ileal augment?
Typically, if their creatinine is 2 or above as a ballpark. GFR can be 30 or less, or something like that. But what happens is continent augment requires more maintenance. The ureteroileal obstructions are harder to deal with, and they have they have stomal stenosis. They're not doing cath, and again, they don't do mucus irrigation. So low threshold for patients with high creatinine and age to go for ileal conduit.
Okay.
So does the length of ileal conduit have some role in this? Like we try to shorten the length or something, or we go ahead with the same, like as we
No, I don't do it any differently.
Okay.
Length typically is, you pick based on the body habitus of the patient. How thick is the abdominal wall? You guys are lucky. Most of your patients are skinny, unlike North Carolina. We have to do a lot of Turnbull stomas. We can't do a straight ileal conduit. So in a very obese patient, other parameters being normal, I much prefer doing a continent augment and bringing a stoma at the umbilicus, which is the narrowest portion of their body wall, rather than bringing an ileal conduit over a pannus, which flops over, so which is very difficult to maintain the angle of the bowel, etc. So continent procedures in a big patient is more or easier than doing an ileal conduit.
Sir, would you consider keeping overnight drainage if the patient has a creatinine of more than 3 and yet we are forced to do an ileal conduit because the bladder is hostile and the upper tracts are deteriorating?
So I need to show that the creatinine came down or is reversible, either with stenting and or continuous drainage, that their creatinine slowly came down to below 2, then they can have options. If they have creatinine fixed, even with bilateral PCN or internal stenting and continuous drainage, then that's what they're starting from. So you need to show with maximal drainage that their creatinine is not declining. Have I answered that question or not? Is that what you were asking?
Other question is, if suppose we had seen this woman or this young lady a little earlier and we had realized her behavior, that she's not compliant and she's not doing CSA, and maybe at a little younger age, would you have considered evaluation of the spinal cord surgery again? Like whether it is complete or incomplete, or does it need revision?
Excellent question. It brings about a patient, myelo patients, that typically they go through pubertal change. They will first present with upper tract changes, and that's due to loss of compliance as their spinal body and becomes longer. Tethering occurs at the site of previous surgery, and detethering of the spinal cord is sometimes helpful to improve their bladder function. That's a different patient who have poor compliance as their presentation. Bladder overactivity is not a typical presentation of tethering of the cord. So she obviously has the same condition of overactivity and under drainage as her problem, and she just chooses or refuses to accept it. If she came as a young adult today or a young child, even a child, we would index her with Botox, and compliant CIC would be the best initial and permanent management for her. It's much better to do that, and we do it in children also now, Botox. So she would have been managed that way. Unfortunately, you just can't teach certain patients what's right for them.
You're right, sir. I would encourage our postgraduates to please clear your doubts, because this is a very important scenario which is being discussed.
So next time I'm going to talk to you. Hopefully many of you will be the same. I'll put up a pre-test for the NGB, and you have to pass that before I go on to the next talk. Otherwise, I'll give you the same talk again.
Okay. Yeah. So Pawan, should
Yes, ma'am.
yeah. So if there are no more questions, we would definitely like sir to we'd like to thank you very much, sir, and we are happy of your association with IJU, and we are thankful for Dr. Chawla, who has brought about this new series. And yes, Pawan, please have your concluding remarks.
Thank you very much, sir, for this excellent lecture and for clearing everybody's doubts. And thank you for your time.
My pleasure. Good to meet you all. Enjoy the game. Bye-bye.
Yeah.
Bye. Thank you, sir.
Thank you.
Bye.
Thank you.